My name is Wynn Phillips. I'm affiliated with the Department of Health Management and Informatics at the University of Missouri here, also with the Center for Health Ethics. And I have I'm also a co-coordinator of the conference. I also have the pleasure of introducing our final speaker, Professor Marshall Kapp. Marshall B. Kapp was educated at Johns Hopkins University, a Bachelor of Arts degree, George Washington University Law School, a JD with honors, and Harvard University School of Public Health with his MPH. He's the director of the Florida State University Center for Innovative Collaboration in Medicine and Law, with faculty appointments as professor, Department of Geriatrics, FSU College of Medicine, and professor of Medicine and Law in FSU College of Law. He is also affiliated with the FSU Pepper Institute on Aging and Public Policy. He's an adjunct professor, Stetson University College of Law, teaching in the Elder Law LLM program. Previously, Professor Kapp served as the Garwin Distinguished Professor of Law and Medicine at Southern Illinois University School of Law and School of Medicine, and as co-director of the School of Law's Center for Health Law and Policy from 2003 to 2009. He is Professor Emeritus from the School of Medicine at Wright State University, where from 1980 through 2003 he was a faculty member in the Departments of Community Health and Psychiatry and taught courses on the legal and ethical aspects of healthcare. He also was director of WSU's Office of Geriatric Medicine and Gerontology and held an adjunct faculty appointment at the University of Dayton School of Law. From 1998 to 2001, he was designated Wright State University's Frederick A. White Distinguished Professor of Service. I'm looking forward to the presentation. Thank you very much for coming. Without further ado, Dr. Kapp.
Thanks very much. Thanks for sticking around to the bitter end. Coming as the absolute bitter end of a 1.5-day conference. It was very full, and unfortunately I wasn't here yesterday, but I know you've heard a lot of excellent speakers. Coming at the end, I feel like Elizabeth Taylor's 8th husband on his wedding night. I know what my assignment is. I'm not sure I can make it very interesting for you. Particularly talking about Medicaid and the Affordable Care Act, but I'm going to do my best for you. How many of you work in long-term care? Not very many, okay. Some of you. Just so I know. So where I want to go with this is my general thesis is long-term care, and particularly I'm going to use a lot of acronyms for simplicity's sake, I hope simplicity's sake. Home and community-based long-term services and supports is what that stands for. In the long-term care arena, to get the correct jargon, we talked today about long-term services and supports. We don't really use the term long-term care anymore. That's not as politically correct as services and supports. So my thesis is that what we used to call long-term care, and particularly long-term services and supports that are home and community-based, was primarily a political afterthought in the Affordable Care Act. There was one provision in the Affordable Care Act that I'll talk about, the Class Act, which was so poorly designed that it's crashed and burned already. There were a variety, and I'll talk about these in a little more detail, of provisions relating to home and community-based long-term services and supports, but they really weren't the central focus. They were really kind of add-ons, primarily, I think, to purchase votes for the Affordable Care Act. But nonetheless, there are some provisions that we'll talk about. I would suggest, I'm not going to belabor this as part of this presentation, that the Affordable Care Act, the future of it and the accomplishments of it are something that we can't predict right now. It remains to be seen how much of the Affordable Care Act actually is going to get implemented. how much of it is going to be successful in accomplishing its purported purposes, how much of it is going to self-implode, how much of it will get implemented but won't make any difference at all. These are all unknowns, I would suggest. The future is uncertain, and so it's kind of ironic that I think some of the home and community-based long-term services and supports provisions that I'm going to talk about may turn out to be the Affordable Care Act's most enduring legacy. So that's where I'm going. So with apologies to those who work in the field and know this stuff, just some basics. What is long-term care? Traditionally, the long-term care world has been divided up into two parts categorically: institutional versus home and community-based, with the clear demarcation based upon the physical location or setting of services. So if care was provided in nursing homes, assisted living facilities, other residential care communities, we generally categorize those as institutional services, whereas services that were provided in adult daycare centers, provided in-home environments by home health agencies, provided outside of a hospice house, a formal institution, but hospice services provided elsewhere, personal and homemaker services provided in the home. We thought of that as home and community-based. That clear categorical demarcation may be changing. In January of this year, the Centers for Medicare and Medicaid Services issued a final rule that amended Medicaid regulations on the definition of state plan home and community-based services under Section 1915C waiver provisions as amended by the Affordable Care Act. So for those who don't work in this field, the translation of that is that Medicaid, the Medicaid statute, created what was envisioned as a medical program, as a program for subsidizing medical services for people who met certain need-based criteria. And home and community-based services generally don't fall within the strictures of the Medicaid statute, and consequently, Congress has authorized a variety of waiver programs that allow states to apply to the Centers for Medicare and Medicaid Services for permission to use Medicaid dollars, including the federal portion of Medicaid dollars, to pay for services that otherwise wouldn't fall within the Medicaid statute itself. And as we'll see, there's been a proliferation of those waiver opportunities in the law. And one might ask, well, why doesn't, if the program is so restrictive, if it so fails to meet the needs, that we have to constantly ask the states to apply for waivers to change their Medicaid state plans to allow them to do what we think they ought to be doing, why doesn't Congress just change the Medicaid statute? That would be a little too much linear thinking. And so it's unlikely to happen. And consequently, we have a proliferation of waiver programs. Well, historically since the Medicaid program, 1915C of the Social Security Act has been the most important waiver program allowing states to get permission from Centers for Medicare and Medicaid Services to amend their state plans to use Medicaid dollars to provide for home and community-based long-term care services. And CMS in January of this year issued a final rule amending the definition of home and community-based services and supports under this waiver program. In other words, amending what states can apply to CMS for that would allow them to spend Medicaid dollars under the guise of home and community-based services and supports. And under this final rule, the home and community-based services definition is no longer just based on location. Instead, it's a more holistic view, which is good for those of us who think home and community-based services and supports are good, but it's a little fuzzy. I mean, that's good from a lawyer's perspective because inevitably it'll generate litigation, but it may not be so good from a programmatic perspective. Nonetheless, under this definition and the rule that was promulgated in January of this year, what counts as home and community-based services for purposes of the 1915C waiver provision is based not just on where the services are provided, but on the nature and quality of the individual's experience in the care setting, taking into account the setting is integrated in and supports full access to the greater community. Setting is selected by the individual from among setting options, respects individual rights, freedom from coercion and restraint, optimizes autonomy and independence in making life choices, facilitates choice regarding services and who provides them. So what that means is that states have a year, which would presumably end unless it's extended in January of 2015, if they want to apply for this waiver to amend their state plans to show that the services that they're requesting Medicaid funding for, the federal portion of Medicaid funding for, meet those criteria in order to qualify as home and community-based. Okay, let me step back then. Who needs long-term care? This may, talking about stereotypes, this may conflict with some of our stereotypes. About 57% of the people who need long-term care over 65, 43% are younger than age 65. So the sort of the demographic picture may be different than what we're expecting, and that's a result of are doing a very good job with what Lewis Thomas used to call halfway technology, where today we can keep people with very substantial disabilities and needs, chronic needs, alive for long periods of time, but needing care over a long period of time when those people would have died years ago. So changing demographic picture. When we talk about who needs long-term care, we're referring to impaired ability to function regarding activities of daily living. Who pays for long-term care? Well, it's private dollars and public dollars. Private sector, a lot of long-term care, particularly home and community-based care, is paid for out of pocket. And there is a growing, but at a very much slower pace than many expected, private long-term care insurance industry. On the public side, Medicare is involved to a certain extent, primarily for post-acute short-term rehabilitation stays. Medicaid is the big actor, the big public actor. Medicaid pays for almost half of total long-term care expenses. So they're the big guy. I was actually kind of taken aback when Dr. Parks was talking this morning, and he talked about how the Medicaid state directors got up and talked about what was most important to them, and 2/3 said behavioral health. I actually would have expected long-term care, because long-term care is a big portion of state Medicaid expenditures. Some funds for long-term care services are provided by Congress through the Older Americans Act, who operate, and those of you who work in this area are familiar, they operate through a network of state units on aging and area agencies on aging, and they fund a variety of community-based services, home delivered and congregate meals, transportation, senior centers, legal assistance, health promotion and adult day programs. Of course, these are not health programs, these are not medical programs, so Medicaid doesn't fund this. There are also state and local appropriations, proceeds in some parts of the country of dedicated ballot initiatives, and the Veterans Administration runs and funds certain community-based services. Now, who controls the details of one's long-term care? The who, what, where, when, and how of long-term care. If I need services, who makes the decisions about those services? Well, if I'm paying out of pocket, if I'm a private payer, either because I'm taking it out of my own pocket or I have long-term care insurance maybe that provides me with money to spend, it's a consumer-directed arrangement by definition. So we talk a lot about consumer-directed long-term care. That's really nothing new for those who pay out of pocket. It's just like anything else. If you go to buy anything else out of your own pocket, that's a consumer-directed arrangement. You decide what you're going to buy and when you're going to buy it, and how it's going to be delivered and all that. However, as we've said, Medicaid's paying over half of the long-term care freight. Medicare pays some. For people that are dependent on public programs, generally it's the funding agency that is directing and controlling the details of long-term care services, although there has been a movement in recent years, in the last decade or so, toward more consumer direction, even regarding the use of public funds. But it's still primarily a funding agency-directed model. So there's a movement, there's a trend away from institutional care toward home and community-based long-term services. Why? Well, first we have to acknowledge why the institutional bias in the first place, because Medicaid, Medicare, which is a factor to a lesser extent, are both medically based programs. They pay for medical services. And that may have made sense if you look at the demographic picture and the healthcare picture in 1965 when both of those programs were created. It makes less sense today, but it explains the bias toward institutional care. People who had substantial impairment in activities of daily living and their function often had no choice but to go to a nursing home if they couldn't be cared for in the home by family or friends without public dollars. But today people want home and community-based long-term services and supports. Consumer would rather be in their own home or family member's home. Most families prefer this. Long-term care professionals prefer this. They understand that for most people, they're going to be happier, they're going to be better in a variety of ways if they're cared for in their own homes or their homes of their family members. There's also belief and a fair amount of empirical evidence that supports it that home and community-based services saves money as compared with institutional care. But we have to remember that one of the reasons that home and community-based long-term services and supports is generally more cost-efficient than institutional care is because of the heavy reliance on unpaid or informal care by family and friends. That's a central tenet in all this. Is a lot of the care in people's own homes or their families' homes is provided on an unpaid basis by their families and friends. And I use the term informal because that's sort of the accepted jargon. It's not a very good term because it's real work, it's hard work, it's nothing casual about it. but nonetheless, that's the jargon that is generally used is the term informal. It's belief that quality of care is improved and quality of life. And of course, those are not always the same things. Those are not always synonymous. Both quality of care and quality of life are improved by keeping people out of institutions or getting them out of institutions and serving them instead in home and community-based environments. And then there's a case that was decided by the U.S. Supreme Court in 1999 that's very important in the movement away from institutional care toward home and community-based services and supports. The Olmstead case, which was, people familiar with the Olmstead case? Okay, let me take a minute to talk about it because it really is important in this push in this direction. Olmstead involved a couple of women who I think were developmentally delayed, but they had some chronic issue that made it impossible for them to live on their own. They were in a nursing home paid for by Medicaid, so the state was paying for their care in a nursing home. They brought a lawsuit saying we have a right for the state to pay for our care out in a home and community-based environment under the Medicaid program, because the Americans with Disabilities Act, the ADA, in Title II, says that any service provided by the government has to be provided in the most integrated setting possible. And a home and community-based environment would be more integrated than a nursing home. And the Supreme Court agreed. The Supreme Court said that if a governmental unit is paying for a service, it has to provide that service to the service recipient in the least integrated setting possible, and that for these women at least, it would obviously depend on the particular client involved, but for these particular plaintiffs, that would be a home and community-based environment rather than a nursing home environment. So every state has an Olmstead implementation plan. There's been a lot of progress since 1999. Not total progress, not enough progress, but quite a bit of progress. And in any event, this helps to explain, along with the other general explanations, why the movement toward home and community-based long-term services and supports. And the various states have differed pretty markedly on their uptake, the rate of home and community-based services, and shifting emphasis away from nursing homes toward home and community-based models. So let's talk about some of the specific waivers. And I apologize that this gets very detailed and very wonkish, but there's no way, when you're talking about Medicaid, which former Chief Justice Berger once described in a case as the most unfathomable law ever created by mankind, coupled with changes made by the Affordable Care Act, there's no way to talk about it without getting kind of bogged down in details. So apologize for that. But we mentioned before the one waiver that pre-existed the Affordable Care Act, Section 1915C of the Social Security Act, that empowers the Department of Health and Human Services, the Federal Department of Health and Human Services, to waive certain Medicaid requirements to allow states to address the needs of certain target groups who opt to receive home and community-based services instead of institutional care. And I've already talked about the final rule that was promulgated in January of this year that changes the definition of what will qualify as home and community-based services. So this is the big waiver opportunity. It pre-existed the Affordable Care Act. Also pre-existing the Affordable Care Act was a waiver opportunity called cash and counseling. States could apply to CMS to include in their Medicaid state plan the use of Medicaid dollars for something called the Cash and Counseling Program. This was originally created by the Deficit Reduction Act in 2005. It's codified in Section 1915J of the Social Security Act. So don't get confused between 1915C and 1915J. It's different pots of money, different programs. And it essentially created a voucher program for consumer-directed home and community-based services. So if you were a state that had a 1915J waiver, you could actually provide eligible individuals who needed long-term care services, wanted to get them in the community, with a voucher to hire whoever they wanted to come in and provide those services that would allow them to stay at home. It's called cash and counseling because of the fear that most of the eligible individuals were not going to be sophisticated enough to manage the system, to go out and find somebody, hire somebody, supervise somebody, fire somebody on their own. And so there was a counseling component as well. That's why it's cash and counseling. And there were several states that implemented cash and counseling and with a high degree of success in keeping people in their own homes or the homes of their family members without some of the horrible predictions occurring that had been made. Okay, to that pre-existing landscape, now there are additions created by the Affordable Care Act. The Affordable Care Act in Title II, Subtitle E, said it's the sense of the Senate that, quote, Congress should address long-term care services and supports in a comprehensive way that guarantees elderly and disabled individuals the care they need. Now, as I said, in reality, long-term care was really an afterthought. They certainly did not address it in any sort of comprehensive way, but they did add on a bunch of provisions, as I say, primarily to buy senators' votes in key states. So we do have something that was added on that I think may ultimately be beneficial in terms of promoting home and community-based long-term services and supports. One provision relates to Section 1915I of the Social Security Act, so don't confuse it with Section C or Section J. This is Section I. Prior to the Affordable Care Act, 2006, the Deficit Reduction Act gave states authority using this waiver provision to provide home and community-based services as a state plan option. Previously, that option had to be included as a waiver. Under the Affordable Care Act, changes made by the Affordable Care Act, for this program, this particular waiver, it expands financial eligibility for services to some additional people, creates new optional Medicaid eligibility groups, allows states to target specific populations. That's important because the general Medicaid statute says to the state, anything you do regarding your Medicaid program has to be done for every eligible individual across the state. This waiver allows states to target this services provided under this particular waiver to particular specific populations, not requiring a statewide basis. And it expands the services states may offer. So that's one waiver program that was expanded substantially by the Affordable Care Act. Section 1915K was created, a new waiver program called the Community First Choice State Plan Option. This was a new Medicaid optional state plan benefit. And obviously, any of these waivers are optional with the states. They all depend on the principle of federalism. They all depend on state uptake, on states applying for these waivers. They're not forced upon states. So this was a new optional state plan benefit, allowing states to provide home and community-based attendance supports and services, personal care services, to people who would otherwise require an institutional level of care. And if a state applied for and received this waiver, the 1915 waiver, and provided services to this new population, attendance supports and services to this new population using Medicaid dollars, the incentive to the state would be that the state would receive a permanent 6% increase in their federal medical assistance plan for CFC, Community First Choice Services. Now, the FMAP, assuming most of you are familiar with the Medicaid program, but if you're not, it's combination, the dollars are combination federal-state dollars. The FMAP is the federal portion of the Medicaid dollars. So the federal portion of the Medicaid dollars that could be used for this particular waiver program would increase permanently, to the extent that any legislation is permanent, which is a big question with the ACA, but to the extent that any legislation is permanent, by 6%. So it's a big incentive. And if a state obtained this waiver and provided services under this waiver, the state could choose either an agency or a consumer-directed service delivery model to handle the details of who's going to provide those services, how they're going to be paid, how they're going to be supervised, whether they're going to be fired, so on and so forth. Another program is called The Money Follows the Person. This is a demonstration program. What an odd concept that the money should actually follow the person and therefore maybe address the person's needs. Money Follows the Person demonstration program consisted of a federal grant to assist states to transition Medicaid recipients out of institutions and back to home or community settings. So the emphasis is different than some of the other programs, which were concentrated largely on keeping people out of institutions. This is aimed at people who are in institutions, primarily nursing homes, and getting them back to home and community settings. This was originally created by the Deficit Reduction Act, but the Affordable Care Act amended this to offer states enhanced federal Medicaid matching funds for qualified services for 12 months, so it's time limited, for each beneficiary who transitions to a community setting. Affordable Care Act created a home health services option, provides states with a new state plan option to provide home health services such as care coordination and case management for Medicaid recipients with chronic conditions with a temporary 90% enhanced federal match. And again, the FMAP is the federal medical assistance percentage. So we'll have time for some questions when I'm through. I don't want to, spend more time than I am going through the details of this, but hopefully you're getting at least a flavor of what is involved with the ACA and long-term care. Another program is called the Balancing Incentive Program, the BIP. Incentives for states to offer home and community-based services as a long-term alternative to nursing homes program. This provided federal matching funds through September of 2015 to incentivize states, and Missouri, I know, has been approved by the Department of Health and Human Services for this waiver, to make certain structural reforms to move Medicaid long-term services and supports recipients from institutions to the community. In order for a state to qualify for this waiver, and therefore get the federal, increased federal matching, they have to provide a single entry point into the system, conflict-free case management services, whatever that means, conflict-free, standardized assessment instruments, and the worse that the state was in the past in terms of institutionalizing people who needed long-term care services versus providing services out in home and community-based settings, the worse a state was in the past, the bigger the bump in the FMAP. So the idea was to really help the worst states in terms of the institutional bias. One provision that is potentially quite important, temporary, it's going to expire in 2019, assuming we're all still around and the ACA is still around then, or it hasn't been extended, is an expansion of the spousal impoverishment protections to individuals who qualify for Medicaid home and community-based services. Under this provision, the states must disregard the income of the community spouse, the one who doesn't need long-term care services, who may keep half of the couple's joint assets. Medicaid eligibility, of course, depends on both income and assets. So, the income of the community spouse would be disregarded in figuring out the Medicaid eligibility of the person who needs long-term care services, and the community spouse could keep half of the couple's joint assets. Previously, this disregard only applied if the Medicaid recipient was in a nursing home. Now it will apply if the Medicaid recipient is receiving services in a home and community-based environment. That's potentially very important for a lot of people. So, some of the policy issues. As I said at the beginning, there was one significant long-term care provision, other than the ones I've just been talking about, in the Affordable Care Act. And that's called the CLASS Act, Community Living and Assistance Services and Supports Act. It was part of the Affordable Care Act. It essentially purported to set up a public long-term care insurance program that would be funded by premiums paid by individuals who chose to participate. The problem was, without going into excruciating detail, it was designed so poorly that it never had a chance of being financially viable. Part of the CLASS Act had a provision saying that it had to be financially cost neutral to the government. It had to be financially viable. The way it was set up, that could never have happened. The big problem with private long-term care insurance, the reason the primary reason private long-term care insurance is not taken off the way many predicted, is the problem of adverse selection. Adverse selection, as I'm sure most of you know, is the insurance phenomenon that the people who are most likely to use a benefit are the ones who are most likely to buy coverage for that benefit. So in the long-term care arena, people who are in their 50s and 60s and even 70s today and relatively healthy say, I'm not going to need long-term care insurance. I understand that I'm going to die sometime, so I'll buy life insurance, but I'll never need long-term care. So why should I buy it? So the people who are most likely to buy private long-term care insurance are the people who are older and sicker and are contemplating that pretty soon I'm going to need this benefit, so it's time to buy it. The problem with adverse selection, when you have only the people buying it who are most likely to need it within a short period of time, is that it drives up the cost of premiums excruciatingly. And insurance companies also will not sell to people who are bad risks. That's what insurance companies do. They underwrite. Well, that adverse selection problem was very much included in the Class Act. It was not avoided in the Class Act. And so they quickly realized that if adverse selection is acting as a big impedance to the success of private long-term care insurance, it's going to have the same effect with this public program. And so the administration, they bit the bullet pretty quickly on this one. They figured it out. The administration announced that they were just going to hold it in abeyance in November of 2011, and then in January of 2013, Congress put it out of its misery and repealed that provision altogether. So the policy issue is, okay, we don't have the Class Act. What do we do to provide a viable source of funding other than forcing people to impoverish themselves in order to qualify for Medicaid if they need long-term care services, whether in an institution or a home and community-based environment? So when Congress repealed the Class Act, had to do something, of course, so they set up a commission. Congress does that periodically when there's an issue that is very important, but it's too hot to handle through the political process, where, of course, there might be some accountability. So they set up a blue ribbon commission to issue a report instead. So they set up a commission on long-term care, a lot of very important and well-respected people appointed to it. I give you the citation. It issued a report on September 30, a very full, comprehensive, thoughtful report. September 30 of 2013, endorsed a package of 28 recommendations. Plus, it also contained, there were 3 or 4 members of the commission who issued what they called an alternative report. It was really a dissenting report. And they called for a single-payer long-term care insurance system. Neither the majority report nor the alternative report have received any attention whatsoever from either Congress or the administration, which is not unusual in the life of these commissions. But for those who want to know more about our long-term care system, this is available, and it's very thoughtful, as I say, and very informative. So it became clear that the commission report was not going to get any traction. So a couple of months after the report was issued, in December of 2013, this nonprofit entity in Washington, D.C., called the Bipartisan Policy Center, which does have a lot of heavyweights, a lot of former national office holders from both parties, launched a long-term care initiative to raise awareness about the importance of finding a sustainable means of financing and delivering long-term care services. And we're going to issue our own report in late 2014. Hasn't come out yet, but presumably it will within a short period of time. And that, too, I would predict will be a very thoughtful and comprehensive piece, well worth reading, to which no attention will be paid. But it's good reading. So what are the challenges? I mean, obviously, this is a hodgepodge. And it affects a lot of lives and a lot of money. So what are some of the challenges? The challenges are, where are we going to get the money to pay for all these good things, all the good services that I've been talking about, that Dr. Parks talked about this morning? Where are we going to get the money to pay for it? At least the public portion of long-term services and supports encompasses a mind-numbing variety of program complexities. I'm not going to give you a test, but if I did, you'd all fail. I'd probably fail, and I study this stuff. How's the average citizen going to get any understanding of this? The question of federalism that I mentioned, variability among the states. All of these waiver programs depend upon the states putting together a waiver application to amend their state plans, getting approval from CMS, and then actually implementing. And the states have varied a lot on their uptake, on deciding whether this is really workable in the state, whether it's worth the time and the expense to apply. And how do we provide these services and supports and the funding for them while maintaining and enhancing consumer-directed models, which many consumers and their families prefer. Not all, but many. Other problems, other challenges, I should say, the workforce adequacy. Even though we could pay for these services, you have to have somebody to provide them. And in long-term care, there's really a shortage of credentialed professionals, other paid caregivers, family caregivers. As I said, the current long-term services and supports model for home and community-based care depends very heavily on family caregivers, usually unpaid family caregivers. Well, is that going to continue? Look at the demographic trends, people having fewer children. Best long-term care insurance, of course, is having a daughter. So, fewer people having daughters, people outliving their children, particularly their male children, is a reality. People, two-couple families where both people have to work out in the outside world for pay. So some big demographic challenges. Financial support for family caregivers. If adult child has to give up a job or cut back on their hours, they take a big financial hit. That's not sustainable over the long term. And physical and emotional support for family caregivers. Lots of evidence that the family caregivers often wear away before the original client. There are also legal issues that I'd be happy to spend a long time on, but I won't get into it unless people have questions relating to the status of workers in consumer-directed home and community-based services. So if I need long-term care services and I'm able, either through my own financial resources or through Medicaid under one of the waiver programs in my state, to go out and hire somebody to come into my home and provide services for me, is that person covered by the Fair Labor Standards Act, the minimum wage, and the other provisions of the Fair Labor Standards Act? Do I have to pay workers' compensation in case they slip and fall in my kitchen and get hurt? I would if I had an outside business, but does it apply to people I hire to come in and care for me in the home? What about Occupational Safety and Health Administration rules? Somebody's washing my dishes or washing my clothes with substances that wouldn't be permitted if I were running a factory, but I expect them to do that in my home. And do I have to pay Social Security? And do they have to pay Social Security? So there's some interesting issues that they're legal, but they're very practical as well if we're going to have this model work. So my proposal, this is kind of a throwaway for you, but my proposal for all this is, and it kind of shows you where I'm coming from and why I'm not as enthusiastic about the ACA as I'm sure some of the speakers you heard yesterday. I would cash out Medicaid and Medicare, mandate and financially empower consumers to purchase, with the help of navigators or case managers, private long-term care insurance with case management services through subsidized exchanges. In many ways, this is what the Affordable Care Act actually embodies for general health insurance. If it's such a good idea for general health insurance, why isn't it a good idea for long-term care? So, okay, so that's my idea. That probably has as much chance of success as the bipartisan policy center or the Long-Term Care Commission having its recommendations come into being. I'm going to stop. Thank you very much. I'm happy to take questions. I know I'm standing between you and beautiful weather. I brought some weather from Florida with me for you. But if there are questions, yes?
So just, one to further extend on what you had already discussed regarding caregivers, with the advent of team care and sort of long-term management of chronic diseases by the team members, and the fact that as some have termed it, ambulatory critical care is being shifted from the inpatient to the outpatient setting, much of which is going to be in the homes. I think there's real concern about what's going to happen to caregivers, more so than perhaps the patients themselves that the caregivers are responsible for. Do you advocate for a voucher system within this, within the proposal that you have, to where we could actually financially support the caregivers and perhaps provide caregivers for caregivers?
It's a very good question. The question was, should we have some way of paying the family caregivers? That's what you're asking. Yes. Yeah, should we have some way of doing that? There are some states that actually do that now, that use Medicaid dollars for that. There's good arguments on both sides. I mean, the argument is it would allow some family members who really want to provide those services to provide those services, which would give them a sense of satisfaction and also allow the care to be provided in the home rather than needing to ship grandpa to the nursing home. So there's some good arguments for that. It would be potentially less costly than Medicaid paying for grandpa in the nursing home. The counter argument to that is, I talked about adverse selection. The other big insurance principle is moral hazard. And I'm sure some of you are familiar with that concept. Concept of moral hazard is if a benefit exists, people are likely to utilize that benefit and, in fact, overutilize that benefit. I'll give you an example, not a long-term care example, but if you're not familiar with the concept of moral hazard, I had a knee replacement surgery done about 10 months ago. They wanted to send me home with one of these machines. It's kind of a perpetual motion machine that keeps your leg circulating for a few weeks. And they said to me, the physical therapist in the hospital said to me, now there's no evidence that long-term this makes any difference at all, but insurance will pay for it. So you ought to do it. What the heck? Do it, even though it won't hurt you, but there's no evidence that it actually will make a difference. Well, I think I'm a little more sophisticated than the average guy on the street, but of course I took it home. Insurance was paying for it, and I used it for 2 weeks. That's moral hazard. That drives up costs of health care without a corresponding benefit. Well, to apply moral hazard in this context, the argument is you've got families who somehow or other, by hook or by crook, are providing services to their loved ones in the home environment now. If we provide a benefit, particularly a public benefit, that would involve payment to them, all of a sudden these same family members are going to raise their hand and say, well, I have to be paid, otherwise we're going to have to ship grandpa to the nursing home. I couldn't possibly do this on my own without this newly created benefit. and that that would squander precious public dollars that could be used for other purposes. So that's what's holding it back, is the fear of moral hazard, that right now people are doing it out of love, they're doing it out of affinity, they're doing it out of reciprocity, but we could change that to where they're only doing it for money.
And can I just add that policymakers and politicians have evidence that that actually occurs. When I was working in Washington, this issue was true with ambulance services in rural areas, with volunteer firefighters. This is true with free care that physicians give. If you put a free clinic in the middle of a rural area, all of a sudden the physicians give less free care. They have reason to worry about that, because that does happen. If you start paying, if a federal government comes through with a big federal program and starts paying for things people are already doing, people do it voluntarily less.
Yeah. I mean, the other term that you hear in the context of moral hazard is crowding out. If you have a public program that will pay for family care, that crowds out voluntary provision of care by family members. So that's the fear. I thought there was, yeah.
Question. Yesterday, Dr. Emanuel apparently gave up on the goal of trying to reduce health care expenditures in the country from $3 trillion, say, to $2 trillion. He was just trying to stave off them rising.
The curve.
Okay, and the ACA has in place some attempts to control costs or reduce costs through accountable care organizations and so forth. Are we headed for a long-term care and nursing home residence cost crisis in future years if we can't control costs? It seems like almost no one has private nursing home insurance because it costs so much.
Yeah, the adverse selection problem.
Spending down, et cetera, aging population. Are we headed for a real crisis here that the ACA had a chance to address and really didn't address, and no one knows how to address?
Well, I think so. I think we've got a crisis now. We've got a spending crisis now. In every state, Medicaid is either the first or second highest expenditure. Some states it's K through 12 education is number one. Some states Medicaid's number one, and of course long-term care is a very large component, if not the largest component of Medicaid. So I would, that's why I really was surprised. I was enlightened to hear Dr. Parks say that the Medicaid directors identified behavioral health, which just shows you how big a problem that is, if they're saying it's a bigger problem than long-term care. But I would say, we've got the crisis now.
Good.
Okay, thank you very much.